system. It will help for urgent drainage or early drainage or conservative management. What is this score? This score we are looking for, number one, for the clinical parameters. Hypotension means that systolic blood pressure less than 90, it will take 3 points. Tachycardia, 1 point, and dyspnea, take 1 point. And regarding the echo, what you will find, if large effusion, more than 2 centimeter, it takes 3 points. RA collapse takes 2 points. RV collapse takes 3 points. IVC plethora take 2 points. And also looking for the etiology of the pericardial effusion. Suspected malignancy, it will take 2 points. Tuberculosis take 2 points. Post-procedure iatrogenic takes 2 points. And the anticoagulation complication, it will take 1 point. So collectively, how can we interpret this? More than 6 points, it means that urgent pericardiocentesis. So it is very important because there is high risk of tamponade and also worsening of the patient. From 4 to 5 points, early drainage. Early drainage, it means from 24 to 48 hours and must be the patient in the ICU for monitoring. If less than 3 points, will be conservative management, and after that, follow up for the pericardial effusion. Take home message from this tamponade. It is very clear now that diagnosis of the tamponade, it is clinical plus echo interpretation. And also RV collapse, it is the most specific. IVC, it is the fastest clue to say that there is already tamponade. And unstable patient, don't delay, you have to go for drainage. Now I'll show you some of my real cases. What is this? It is already large pericardial effusion because already the size more than 2 centimeters. It means it takes how many points? It takes 3 points, okay? And if you look here, RV, the diastolic collapse, it means it will take another 3 points. Look here, already RV, diastolic collapse, and the large effusion. Here it is very clear. And also started here, what is this? It is RA collapse. RA collapse, it occurs at the late diastole and early systole. So RA collapse also, it takes 2. So we have now, how many? We have 3 for large effusion because more than 2 centimeters, and also 3 for the diastolic collapse of RV, and also 2 because of early diastolic, the early collapse of the RA. So we have 8. We have 8. This is showing that M mode, showing that diastolic, the collapse of the RV free wall. So we have 8. At the time, 8, it means what? It means the needs for what? It is more than 6. It needs urgent pericardiocentesis. And that's it. We can assess the severity of the pericardial effusion and say that it need already pericardiocentesis or not. Echo in pulmonary embolism, echo, it is very important in pulmonary embolism. Why? Because it is very easy, available, and it doesn't need contrast or any radiation. Pulmonary embolism algorithm for the, by the echo, you will look for the RV more than LV, septal flattening, McConnell sign, and 60-60 sign. I'll go to this. If you suspect all this, you have to go for CT angio, and after that, go for definitive management, which is a thrombolytic therapy or mechanical embolization, mechanical thrombectomy. RV dilatation, if it is already the size more than 4.2 centimeter in the basal part of the RV, or 3.5 in the middle part of the RV, and also RV to LV ratio more than 1. For RV dysfunction, we are looking for TAPSI. TAPSI normally, it is more than 1.7. In this condition, will be less than 1.6. Another 2 minutes. Okay? In addition, also, we are looking for the tissue Doppler velocity, which will be in the annular of the tricuspid valve less than 10. McConnell sign. McConnell sign, just to describe for this, one of the important signs for diagnosis of the pulmonary embolism. It will be, in this condition, will be dilatation of the RV, will be the basal and the mid part of the RV will be akinetic, with bulging of the middle part, and the sparing the apex, which will be hyperkinetic. It is called as McConnell sign, and you see here, the basal and the mid part, it is already akinetic, but sparing the apical part, which is hyperkinetic, called the McConnell sign. McConnell sign, it will be suggestive of the massive pulmonary embolism. What is about 60-60 sign? 60-60 sign, it means that pulmonary acceleration flow time less than 60 in presence of the tricuspid regurg gradient less than 60. It is new sign they discovered. If it is present, it is highly suggestive for massive pulmonary embolism. In addition to the McConnell sign, it increased the sensitivity and the specificity for the presence of the massive pulmonary embolism. So from the echo, in the quick echo in the emergency, you can look for the parasternal long axis to look for the RV dilatation and also collapsibility of the RV in the diastole, and also in the apical fourth chamber, large RV more than LV, and the presence of the McConnell sign, and this is flattening of the septum, and it is already plethora of the IVC. All this will help for diagnosis of the pulmonary embolism. This is one of my case also, short axis, see that flattening of the septum and the dilatation of the RV. And here also the tricuspid regurg gradient, it is less than 60. And here also for tissue Doppler, for the less than 10. And this is dilatation of the RV. This is the patient after we did already thrombectomy, mechanical thrombectomy. So see, all what we saw before already improved dramatically after thrombectomy. That's why it is very important in this condition for the patient to be already diagnosed in emergency by the focus. If you give me 1 minute, I'll finish.
Already passed the
1
time,
minute.
so,
Okay. Also, the role of echo in acute chest pain. Acute chest pain, as you know that already in acute myocardial infarction, all of you know that will be wall motion abnormality segmental. And also acute pulmonary embolism, we say that already all the criteria. What about acute aortic syndrome, which is very important to look for this already in emergency. We are teaching our colleagues. You have to look in the parasternal long axis for the patient with acute chest pain to rule this. Is there any aortic root dilatation? Is any aortic regurgitation or pericardial effusion? Because these three things already, it is a finding, raise a suspicion of the presence of acute aortic syndrome, especially that aortic dissection like this. Especially, this is by TE, showing that already the feeding or that entry point. This is the true lumen, this is the false lumen. This is aortic regurg for the patient with aortic dissection with dissecting flap. It is very clear. And here also the entry point is very clear. So take home message, echo is rapid bedside life-saving tools in emergency medicine. Use of the POCUS systematically in emergency, it is very important. And the POCUS is a goal-directed exam. It is not comprehensive or full exam. Thank you.
Thank you, Dr. Ala. Thank you. It's very informative, very informative. And let's see, maybe there is a lot of questions. And this is, raises the importance of ultrasound for emergency physician, and even replacing now the regular stethoscope nowadays. So if there is any questions from any of the audience. Dr. Bahajit, the mic, do you have the mic here somewhere?
Dr. Aladdin, thank you very much. It was very nice. And this is one important thing that we need so much in our practice in the emergency department. I don't ask questions, just short comments. Thank you very much. It really was very nice. And next hall, 1 hour ago, I was there, we were talking about this issue. I had a question to the audience. I just want to repeat it to this audience also. Who doesn't have stethoscope in this class? Does everybody has it? Stethoscope. You. So why? Because it is important. It is very simple now. We do it. We use it. The ultrasonography is the same. Will become the same. In 2 years later, or maybe, many of you, you will carry your ultrasound in your pockets. It's very easy, not so far. You will you keep your ultrasound in your pocket, and you use it not just in bedside. You use them outside. Now, it is not for in bedside. It is going to be used for outside, in your home, in ambulance, in autobus, in streets and everywhere. It will become very clear and very simple and very useful. So that is why I'm an old man. I suggest my friends, the young one, please and please, do your echography, ultrasonography yourself. If you don't know, do it immediately. Because it will become very important tools for you, much more than stethoscope, much more than stethoscope. So, and then it will show the colors. And if it will say you have a cyst in liver, it will give you a report to you, not just show, not just view. They give the reports to you. Yes, there is for example, an upset in kidney. It say you give a report to you, not just views. Thank you very much for reminding this very important issue.
Okay,
thank you.
Just to emphasize that the importance of the POCUS, it is very important. And just to say that it is not complete study, you have to see severity of the mitral regurg or like this. No, it is very important for detection, early detection of the important emergent cases for the management.
Yes.
So you have to look for, as we said already, for that, give the answer, yes or no. There is something, yes or no. There is dissection, yes or no. And after that, all the details, we will do this. For the cardiologist who will do this in the OR or in other things. But for you, you have to detect and direct the patient.
This is a really very important point. Using the ultrasonography, echocardiography is not just monitoring. It is not the monitoring only, not just. It helps you direct your management because it is dynamic. It helps you and directs you for the management. Thank you.
Thank you very much, Dr. Bahjat. Truly, it's very important, as you mentioned, Dr. And we're not talking about comprehensive echo that's been done by the cardiologist. We're talking about bedside ultrasound that's identifying life-threatening condition. If it's not identified, patient might go into big morbidity or mortality immediately. The regular echo, it has the constraint of time, learning curve, the skills. So we're not talking about conventional echocardiography. This is your area. But I agree with you. And that's why now we're teaching our residents about the POCUS and the extended views and how to identify other causes of shock or even as part of the rush protocol, for example. Okay, any other questions for Dr. Alauddin? So thanks a lot. Thank you a lot, Doctor, for this nice and impressive presentation. We will still have you again for the next presentation, which is related to new modality in management of cardiogenic shock. So hopefully we'll learn a lot also from this presentation. Thank you.
Good morning. I would like to thank the organizing committee for inviting me to participate in this conference.
No,
please.
not this one. There's another one.
Bu değil, kardiyojenik şok yazan.
New modalities in management of the cardiogenic shock. Yes.
This is the one. Yeah.
Yes. We'll talk about different subject, which is the new modalities in the management of the cardiogenic shock. Before we go for these new modalities, we have to know what is cardiogenic shock. Cardiogenic shock, it is a life-threatening condition that demonstrate early recognition and the timely intervention. So it needs early diagnosis. Why the cardiogenic shock still matters? It still matters because mortality remains 40 to 50% despite reperfusion. And also outcome depend on the early recognition and the escalation for the management, which is very important. What is the department concerned with this? Is the emergency department, because he's the first one to see this in front. Definition of the cardiogenic shock, it can be defined as a state of the end organ hypoperfusion due to impaired cardiac output caused by left ventricular, right ventricular, or biventricular dysfunction. This will end by both clinical and biochemical manifestation of inadequate tissue perfusion. That's why when we talk about cardiogenic shock, we are not talking about the blood pressure lower than 90. We are talking about poor tissue perfusion, which is the end result of the cardiogenic shock, which is very important. The diagnosis of the cardiogenic shock reached through combination of clinical characteristics and objective findings. Objective findings, we look for the hemodynamic parameters, which is the systolic blood pressure less than 90 millimeter mercury for at least 30 minutes, or requiring vasopressors to raise the blood pressure more than 90 and making the mean arterial blood pressure more than 60. Cardiac index less than 2.2 and the pulmonary capillary wedge pressure more than 15. This is all in addition to the signs of the end organ damage. So this is the objective things. Also objectively from the biochemical point of view, there will be elevation of the lactate, which is very, very important. And also abnormal liver function test and also increased renal parameters, in addition to the pro-inflammatory markers such as cystatin C, interleukin 6, or the presence of the B-type natriuretic peptide BMP, which is mainly causing the peripheral manifestation of the edema and all other things, as you know. From the clinical point of view, looking for manifestation of the low cardiac output, which is mainly manifested by an uncomfortable patient with cold and mottled extremities, jugular venous distension, peripheral edema, dyspnea, tachycardia, and reduced urine output. So, for diagnosis, not looking only for the blood pressure, we have to look for all things, clinical characteristics, and objectively and mainly biochemical parameters like increasing lactate. What is the causes of the cardiogenic shock? Cardiogenic shock causes mainly due to acute cardiac event. The most common is myocardial infarction, cardiogenic shock, complication, acute exacerbation of the congestive heart failure, and also other etiologies like myocarditis, the presence of the pulmonary embolism, and also serious arrhythmia and severe valvular disease. What is the classification of the severity of the cardiogenic shock? Now there is new classification for the severity of the cardiogenic shock, which is SCAI, which is the Society of the Cardiovascular Angiography and Intervention. They both already classification severity of the cardiogenic shock, going from stage A, which is at risk, going by the end by the stage E, which is the extremes. Which this is very important because it informs the strategy for the management, including mechanical, either pharmacotherapy or mechanical circulatory support, as we will come. What is the classification of the SCAI for the shock? As we said, stage A at risk, there is no hypoperfusion. Stage B, beginning of the shock with the only hypotension and tachycardia clinically, but no biochemical markers. Stage C is starting of the cardiogenic shock, which is the classical shock, which will be hypoperfusion and increased lactate. Stage D, deteriorating cardiogenic shock with escalating of the pharmacological management and the needs for the mechanical support. And the E extremities like cardiac arrest and profound shock. So you have to put in your mind, shock, it must be, there is biochemical markers elevated in addition to the clinical picture. Why SCAI classification matters? Because it guides timing for the mechanical support, which is very important for this patient, and also has prognostic value, and it is now recommended by AHA, ACC, and ESC, all recommending this. Now coming to our rule in the emergency room. What is the rule in the emergency room? What to do for algorithm for the cardiogenic shock? Number one, as we said, must be a rapid diagnosis, rapid recognition of the patient, rapid suspicion of the patient already in cardiogenic shock, and bedside echocardiography. As we said in the previous lecture, you see that the importance of the focus or importance of the echo, because it looks for the cardiogenic shock and it can diagnose which type of shock is there. It is cardiogenic by low ejection fraction. It is hypovolemic by the small LV. It is already distributive hyperdynamic LV, whatever, and also dilated right side like this in case of pulmonary embolism. So it is very important for the ER physician to know rapid diagnosis from suspicious and also bedside echo, and the early lactate and the organ perfusion assessment. That's why lactate, it is now coming. You have to look for lactate for the biomarkers to say that it is cardiogenic shock, and avoid fluid overload and reassess dynamically. It is very important. Management of the cardiogenic shock. Before management, you have to know the etiology. So we have to, our target here to say that there is LV failure, RV, or biventricular dysfunction. And also will help you also after that by the pulmonary artery catheter and the Swan-Ganz catheter. It will help you to diagnose the hemodynamic parameters. It will show you already the pulmonary capillary wedge pressure, right atrial pressure, cardiac index, and the cardiac output. Why all this? Because all this will help us. These hemodynamics parameters will guide mechanical support deployment and also selection in order to optimize the treatment and improve the outcome. That's why from the guidelines, as we said that for the management of the cardiogenic shock, pharmacotherapy. Pharmacotherapy, just to highlight about the update of the guidelines. Now, norepinephrine, it is the first line vasopressor in the ESC and the AHA. Norepinephrine. Dobutamine and milrinone can be added if there is low cardiac output state. But avoid dopamine because it will increase arrhythmia and increase mortality. Early mechanical support. We are doing all these things for detection of the early detection of the patient who needs mechanical support, because it is life-saving. From escalating drugs to early unloading. We are started already by pharmacotherapy. Patient is deteriorating, not improving with increasing the amount of the inotropes. So you have to think about unloading of the LV by mechanical support. Myocardial, the goal for the mechanical support is the myocardial protection and organ perfusion to improve the condition of the cardiogenic shock. The device's choice depends on the shock phenotype, as will come to this. Now you have to ask your questions, yourself questions. When to start for mechanical support, who to start, how to start, whom and what. When to start, as we said, as early as possible. Early decision and intervention are probably crucial to prevent multi-organ failure and improve the outcome. But it must be tailored to your patient. You look for the patient hemodynamic status and also underlying burden of the comorbidity, age, and frailty. How to study? Involve selecting appropriate device and the technique, which must be also tailored for your patient condition. What to study? As you know that all the devices we are utilizing for this, intra-aortic balloon pump, and also percutaneous ventricular assist device, mainly Impella, and veno-arterial ECMO. The choice of the device, it is depend on the cardiac dysfunction, involvement of the right ventricle, as will come for this, underlying etiology, and also patient anatomical and hemodynamical characteristics. So everything must be tailored for your patient. Whom to start? As we said before, acute myocardial infarction patient complicated by cardiogenic shock, acute heart failure, refractory patient with cardiac arrest. But there is very important thing here. Not all the patient to start for this, even if it is indicated. You have to look for other thing. Potential reversible causes must be reserved for the patient with potential reversible causes, not hopeless case, and give this. Number two, also patient potential candidate for the heart transplantation or patient requiring bridge for the definitive therapy. Effective use of this temporary mechanical support, it will be the role of the shock team, as will come, who is the shock team. Device selection. Now, you already decided that the patient needs mechanical support. Which already modality you will utilize in this condition? You have to put in your mind already ECMO, Impella, it will decrease, it unload the left ventricle. Veno arterial ECMO, it's often will increase the afterload. Despite it will already very good for the patient with biventricular failure and also respiratory failure, but it will go with increased afterload. So you have to put this in your mind for selection, as will come after that. Left ventricular, this is Impella, will require good RV function and good oxygenation. So it's not only to put the Impella in the left side, that's it. You have to have normal right ventricular function and normal oxygenation. Otherwise, we'll go for other modalities. Whereas veno arterial ECMO is reserved for the most critical scenario due to ability to provide both biventricular cardiac and respiratory support. It is very important for advanced cases to utilize veno arterial ECMO, not Impella. Device selection flowchart, very easy, very simple here. LV failure with overloaded, what you will select in this condition? We'll select Impella, okay? But must be RV normal function. Biventricular or respiratory failure, we'll go for veno arterial ECMO. Veno arterial ECMO plus LV distension, because as we said that veno arterial ECMO, it will increase the afterload. So in some patient, it will cause LV distension. In this condition will be combination between veno arterial ECMO and will add Impella, called as ECPella. In this condition, we will utilize both already ECMO and Impella. RV shock, there is another devices, Impella RB on the right side, and Protec Dew, I'll give you example of this. Regarding Impella, all of you know about Impella. It is already active LV unloading and improve hemodynamics, and now they are very crucial now, looking for do unloading concept, because to try to fasten already the unloading of the left ventricle. This is the Impella. Already, it is already, this is in this condition, we insert through the LVOT retrogradely, and this is the whole Impella. This is the inlet part of the Impella. This is the outlet part. Inlet part will be in the LV cavity, which takes blood, and after that, going to the outlet here in the ascending aorta. From echo point of view, for our role in this condition, to tell the interventionist the proper position for Impella. We are looking for this. It must be across the the aortic valve. So it must be this measurement from the aortic valve to the inlet must be 3.2 centimeter, and to the already big tail part 5.5 centimeter. So we are looking for this and telling already it is in proper position. ECMO. There are two types of ECMO. I will not go for details of this, but just giving a hint. Veno arterial ECMO, which can be used for heart and lung support, and the veno-venous ECMO, which mainly used for the lung support only, and it is also the choice of the ECMO team. Veno-arterial ECMO, it is provided support for the patient heart and the lung together, and in this type ECMO, it will take blood from large vein and goes through the pump to the oxygenator outside and return back to the large artery, and in this condition bypassing the failing left ventricle. Veno-arterial ECMO emergency, it is rapid full cardiopulmonary support, but have high afterload, and it can cause LV distension. That's why we said sometimes in LV distension we are adding Impella, we call that Ecpella. Early LV unloading recommended by the ASC, which is adding Impella for this condition. This is very simple, the way for the peripheral ECMO. We are taking the blood, venous blood, from the large inferior vena cava vein and going through the pump, which is suction, and going to the oxygenator, returning back to the aorta. That's why it will be in opposite direction for the normal flow. That's why it will increase the afterload. This is done by surgery, central part done by surgeon in the open cardiac surgery. ECMO plus Impella, which is called as Ecpella, it improves the pulmonary congestion and reduce LV strain. And now many observational studies suggesting this because it improving the mortality. What's called as tandem heart, it is also the same thing. If the LV is failing, we are using what's called as tandem heart. In this condition, it is integrated through the inferior vena cava and septicectomy, and going to the left atrium, taking the blood from the left atrium, taking it because it is oxygenated already, it is not going for oxygenator. So and returning this to the aorta from the outside. Called the tandem heart. What about the right side failure? In the right side failure in this condition, what's called as protect due. Protect due, it is dual lumen cannula that inserted percutaneously in the right internal jugular vein. It will take blood from the right atrium and return the oxygenated going outside for oxygenator, and after that going to the pulmonary artery directly, bypassing RV, because RV here will be failure. This is the protect due. It started, as we said that already, there is double lumen here in the internal jugular vein. The first one, it takes from here, it takes deoxygenated blood outside through the oxygenator, and returning this back to the already pulmonary, to the pulmonary artery.
Dr. Ala, I think for the sake of time, you have more slides?
The last two slides, what about revascularization in patient with acute myocardial infarction, cardiogenic shock? Before, you remember that we said that or full revascularization for the all things for the shock. Now, from the shock trials, said that no, only the culprit, only to be already done PCI. Complete revascularization now deferred. We talked about what is the shock team. Shock team, it is multidisciplinary team from ER, ICU, cardiology, and the cardiac surgeon. It is very important. This is the team who will take the decision. I'll skip this. To take decision for the putting the devices. So this is slide summarize what is the management of the cardiogenic shock. As we said, cardiogenic shock can be pharmacotherapy by giving that noradrenaline, and if the patient has already LV, low cardiac output, we can add dobutamine or add milrinone, and also choose that mechanical devices like intra-aortic balloon pump, and also Impella, and using of the ECMO, and we can add also other things for if the LV also affected. The future direction now, you are looking for biomarkers guided escalation. As we said before, because biomarkers, it means that it is tissue perfusion problem. That's why don't rely on the blood pressure, giving vasopressors and say that the patient improving. You have to look for the biomarkers. So they are looking for the biomarkers now. Take-home message, you have to think about SCAI staging early in the ER. It is the role of the doctors in the ER to see the severity. Early mechanical support saves the myocardium, so don't delay for mechanical support. And also the shock team is very important. And to conclude my talk, management of the cardiogenic shock undergone significant transformation with advent of the ECMO for admission of the Impella and the mechanical devices from intra-aortic balloon pump through Impella, through veno-arterial ECMO, and the Protect Due on the right side. Clinician now has diverse arsenal to tailor cardiogenic shock management based on the shock severity, etiology, and the ventricular involvement. Integration of the SCAI staging, invasive hemodynamic monitoring, and the multidisciplinary shock team has further refined the diagnosis, risk stratification, escalation, strategy, and outcome. And thank you.
Thank you very much, Dr. Ala. This is, I think we went too much technical into beyond emergency medicine recognition and resuscitation. So if I have one question, where you stopped, which related to biomarker. Because for emergency physician, what's matter is the early recognition, as you said, and starting the early treatment. What about the new modalities in biomarker like interleukin-6 or adrenomodulin and DPP3? So any future direction for early detection of these with the newer biomarkers, rather than the conventional biomarkers like the BNPs and lactate?
They say that it is additional, but the most important thing is lactate. And they are putting now the cutoff point, started to look for the cutoff point. They put cutoff point now 2.5 lactate. If it is increased more than 2.5, it means that already.
But you know, lactate is not very specific for the heart. They were looking for more specific tissue perfusion modality that can detect early cardiogenic shock. Mm-hmm. So I think there will be more future, as you said, for more biochemical modalities in the coming future.
But till now, they are talking about lactate and other things which you can additional like BMB and liver, but mainly lactate.
Any other question, Dr. Bahaj?
And also, actually, we have exceeded our time very much.
Last question.
Last question. Last question. I want to say your. No. I want to stop after you, of course.
Dr. Aladdin, thank you very much for this nice presentation. I will make a very short statement. There is nothing to say to doctors for the patient who admit to emergency department with cardiogenic shock. We have two missions, recognizing and start treatment. But this is not the problem. The problem is that we have so many patients that in emergency department will let them to improve the cardiogenic shock. This is really, really very important. Regarding this point, my question is to you that when you go back through to your residency, initial of your residency, which of practice of you want to change? Understand it?
Yes.
Okay.
Our professors were teaching us always about shock before all this advancement. They said that you have to look for your patient. Look for hypoperfusion. Not telling us about the biochemical result or anything. Look clinically for your patient. Already the manifestation. But now started with the biochemical changes and all these things, it is giving one step to help you to go more. So the clinical, I say that clinical is very important for suspicion.
Thanks a lot, and I'm sure Dr. Ala will be around for any further questions. Thank you again, Dr. Ala. Our next
And
presentation.
also, next speaker is Professor Ayman Elmanyar from Hamad General Hospital, Doha, Qatar. He really gave a lot of effort also to the scientific program, but unfortunately he couldn't attend to this Congress because of the flight cancellation of Qatar. So we will listen him online. The first subject is ST elevation MI equivalent, how to approach, and then the killer ECG findings should not be missed.
Good morning. I would like to thank the organizing committee for inviting me to participate in this conference. My presentation is about the ST segment elevation myocardial infarction equivalent. I have nothing to disclose. So ST segment elevation myocardial infarction equivalent represent coronary occlusion without meeting the traditional ST segment elevation. So we will not see the expected ST elevation in the ECG, but we will consider it as ST segment elevation myocardial infarction regarding the treatment. So there is about 6 types of ST elevation myocardial infarction equivalent and are equally important to recognize a timely fashion because some of them are considered as pre-infarct condition, and if not diagnosed early, it will be transformed to the transmural full thickness myocardial infarction. So emergency physician must note, and he should note these varieties of ECG because he need to involve interventional cardiologist early because those patients require emergent PCI to minimize the morbidity and the mortality. So we'll talk about this variety, including De Winter syndrome, Welling syndrome, anterior infarction, RV infarction, hyperacute, and so on. Now we'll start with Welling syndrome. Welling syndrome describes ECG changes which represent a reperfusion pattern. So the ECG, we are not saying now it is ischemic change. No, it is a reperfusion pattern that happens after ischemic event. So there is coronary occlusion, then reperfusion. So this is the Welling syndrome. This Welling syndrome is characterized by severe proximal LAD coronary artery stenosis. So in those patients with Welling syndrome, when they came with chest pain, the ECG will be almost normal. When the patient relieved or subsided, the ECG changes appear. It can be type A or type B. Type A, we will see biphasic T-wave inversion in V2 and V3. As you can see in the gray tracing. You can see in the yellow one that there is a T-wave inversion, deep T-wave inversion. This is type B. So there is 2 types of Welling syndrome. So the diagnosis of Welling syndrome, because we consider it as a pre-infarction also, you should not let the patient lose the R wave and should not allow the Q wave to develop. So the diagnosis requires preserved R wave progression, no precordial Q waves, there is minimal or no ST elevation at all. And these T waves are recorded mainly in the V2 and the V3. So now the Welling syndrome is the ECG changed after the pain relief. And if we do angiography, it will show tight proximal LAD stenosis. This is a study of 120 patients with acute coronary syndrome. And they found that 15% of those patients had Welling syndrome, mostly type A, the biphasic T inversion in the anterior lead. So Welling syndrome is prevalent in about 14 to 18% of patients who came with acute coronary syndrome or mainly unstable angina. So acute coronary syndrome in this study included the unstable angina and non-ST elevation myocardial infarction. There is no ST elevation myocardial infarction in this group. So they found that 4% of patients with non-STEMI alone are having Welling syndrome. So they conclude that 15% of acute coronary syndrome will have Welling regardless of the type of acute coronary syndrome, regardless it's unstable or non-STEMI. So non-STEMI and the unstable, the difference here is the cardiac marker. If the cardiac marker are troponin positive with Welling changes, Welling pattern, this will be called non-STEMI Welling syndrome. And this can be happening in 1/3 of the total non-STEMI patient. If the cardiac enzyme negative or normal, this with a Welling pattern, this will be considered an unstable angina Welling. And this can be seen in 1/5 of the total unstable angina patient. So you can see these changes in the upper tracing, the biphasic. In the second one, there is T inversion. In this patient, after 20 minutes, you can see it converted to extensive or massive infarction. Only 20 minutes between the T inversion to see the extensive infarction. This is why it is important to pick up this Welling at this stage. In this study, they didn't observe any statistical significant association between Welling syndrome and the age or gender. However, it is mainly occur in males and in patients more than 60 or equal to 60 years. Also, they didn't observe that Welling syndrome is associated or linked to a specific risk factor. However, it occurs most of the patients are diabetic or hypertension. Dyslipidemia only in some case report. So this is figures and the numbers we mentioned. Still, it is not so accurate because it was collected from small sample size studies. So again, Welling syndrome care mainly in patient with patient is pain-free. We mean here pain-free means after attack of chest pain, this not apply for patient who didn't have chest pain at all, but chest pain, then the pain subsided. In the chest pain, there is no ECG change. In the pain-free, there is ECG changes. As you can see in the upper tracing, there is no significant changes. And you can see in the second one, there is no pain, and you can see clearly the biphasic T inversion. However, you should know that first we should stress on this point that repeated ECG monitoring is recommended in this case to pick up early the changes. However, this deep and or biphasic T-wave inversion are not pathognomonic and it can occur in ventricular hypertrophy, coronary vasospasm, myocardial bridging, intracranial hemorrhage, which is very important to exclude. Those patient has T inversion. And of course, the treatment of Welling's is contraindicated here. Sepsis-induced cardiomyopathy, substance-induced vasospasm like cocaine or marijuana. So this ECG change should be linked to the history, examining the patient and cardiac marker. Sometimes you can read about Welling syndrome or Welling pattern. Pattern means there is ECG changes but no clinical manifestation, no symptoms, I mean. So Welling syndrome, unlike Welling pattern, is defined by the presence of typical ECG changes, as we said, during and post chest pain, in conjunction with significant coronary stenosis, proximal LAD. Willing better does not necessarily indicate critical ischemia and should not be interpreted as a definite evidence of obstructive coronary artery disease unless confirmed angiographically. Because Willing pattern can be seen in spontaneous reperfusion, coronary microvascular dysfunction, post-ischemic T-wave changes. So Willing pattern or Willing syndrome supporting early diagnosis, timely referral and intervention, this will lead to better outcome. So whether it's pattern or syndrome, you have to consider this four things: the symptom interpretation, the serial ECG, the cardiac biomarker, the angiography. And you can do echo before angio to confirm if there is anterior wall hypokinesia. And please, if you suspect Willing syndrome or the ECG show Willing better, don't send patient for stress test. Stress test here is contraindicated. This was the first case report in my life I published 20 years back. They called me for a patient in the emergency with chest pain and normal ECG. So when I saw the patient, there was no pain. ECG was unremarkable, as you can see in the upper one. And the cardiac marker 3 sets were negative. So before I discharged the patient, I asked to repeat the ECG just to confirm this. At that time, there's no pain, but I found this biphasic T-wave clearly in the anterior lead. So we admit the patient, and the coronary angio done in the early morning and showed tight proximal LAD stenosis requiring stenting, and it was doing very well. The second entity of the ST elevation myocardial infarction equivalent is the posterior myocardial infarction. And the posterior myocardial infarction are easily missed because of the absence of ST segment elevation. If it comes as posterior MI alone, so it occurs in about 20% of all MI, but in isolation 3%. In isolation, you will see like this part of the ECG, the right side, you can see ST segment depression, T inversion, and no ST elevation. ST elevation, you can see it in the inferior wall because it can more common with the inferior wall, but it can come isolated, so you will not see ST elevation, only ST depression. And in this case, you have to do the posterior lead V7, V8, V9. However, if this is changed in the posterior lead not present, don't exclude posterior MI, especially in the troponin positive. You can do echo and you can confirm also with the angiography. You see here this patient had angiography and showed the circumflex and right coronary artery stenosis. The third one is isolated RV involvement or RV infarction. It is uncommon, but in 1/3 of inferior myocardial infarction, you can see RV involvement. Why we should search or look for the RV or exclude the RV? We should do this because the RV, right ventricular infarction, is a preload dependent, meaning that the patient needs fluid and inotropes. He doesn't need the nitroglycerin, doesn't need beta blocker, doesn't need morphine, as these three are contraindicated if the patient with RV infarction. It will, if you give this medication to the patient, he will go for shock. It should be suspected also if there is in V1 you can see ST elevation, but not always there. If you have inferior infarction and hypotension, you should suspect the RV. you can do the right ECG leads, V3R, V4R. However, if it's also not there, you cannot exclude it. So as you can see in the ECG, is the depression and also the anterior, as we said before. So again, RV infarction is a part of this entity. Once you have inferior infarction, hypotension, clear back, a lung, clear lung, and distended jugular, you have to think about the RV infarction. The fourth entity of the ST elevation myocardial infarction equivalent is the AVR lead that had ST elevation. This is the only lead can have ECG ST elevation in AVR, and this is a forgotten lead. Most of the physician can overlook this ST elevation here, as you can see in this ECG. This ST elevation is AVR is very important, especially with the other leads showing ST depression, because this will indicate left main coronary artery stenosis, proximal LAD stenosis, or 3-vessel disease. So this is very important. The ECG, you can see only ST elevation in the AVR and ST depression in the other leads. The fourth entity of the ST elevation myocardial infarction equivalent is De Winter syndrome. De Winter syndrome, you can see in the ECG, at 1 to 3 millimeter upsloping ST segment depression, as you can see in the first ECG here. This is upsloping ST depression. There is no ST elevation. So this in the anterior chest lead with tall symmetrical peaked T, as you can see in V2 and V3. And the symptom suggestive of acute coronary syndrome with this pattern, you now have the diagnosis of De Winter syndrome. The pattern can be syndrome if there is symptoms and other confirmatory tools. So once there is acute coronary syndrome symptoms, this Wellen pattern in the ECG, De Winter pattern in the ECG, upsloping T with a peaked, as you can see, the upsloping ST segment and the peaked T. Coronary angio in this patient include mainly LAD, tight stenosis also. However, there is what's called typical De Winter. It can happen in the other branches like right or circ. So De Winter require immediate intervention, like the BCI. You have to send the patient for angiography, and he will need stenting. However, if the stent or BCI is not available, you can, it's within the time of the allowed, you can use thrombolysis, and some cases showed good result in the absence of BCI. Why this De Winter is important? Because it is a dynamic phenomenon. You can see as in ECG this the De Winter pattern, and after stenting, the ECG normalized, and you can see this pattern and then extensive infarction or cardiac arrest within minutes or within few hours if you didn't pick up this diagnosis, and you can see in the ECG. So in this case, it is very important to have continuous ECG monitoring also, because the De Winter syndrome again is not benign at all, and it can be transformed in even Wellen syndrome and to extensive MI and to VTAC and VF if not early diagnosed and treated. So in conclusion, ECG is not 100% sensitive or specific for significant coronary occlusion. The absence of ST segment elevation does not rule out acute myocardial infarction. The patient is requiring PCI even though the ECG didn't meet the ST segment elevation criteria. Serial ECG are crucial. So ST segment equivalent represent coronary occlusion without meeting the traditional ST segment elevation. All varieties of ST segment elevation myocardial infarction equivalent are equally important to be recognized in a timely fashion. Emergency physician must know to involve the cardiologist for early PCI because this early PCI will minimize the morbidity and the mortality. And the example we mentioned here is the winter, Wellens, Sturgeon eye, the left main as we did in the AVR, ST elevation, the hyperacute T in early manifestation or early sign of myocardial infarction. The last one was a new left bundle branch block. It should be considered as myocardial infarction, but it is now not included in this equivalent because there is criteria to measure the ST segment elevation and to consider it as MI. This is the source of the information. This is the references, and this is what we published this year about the winter and including all the ST elevation myocardial infarction equivalent. And thank you.
Thank you so much. We exceed our time very much, but there is one more presentation. Do you want us to continue? I want to ask you just the killer ECG finding. So I think you stay and listen. It's okay? Okay. Okay, Gizem, go on.
Close. To interpret the ECG correctly, you have to examine the patient carefully, talk to the patient, you have to listen to his complaint. Patient is not conscious, listen to the relative, and if available, compare the ECG with the old ECG. There are certain signs on the ECG that can tell you the diagnosis, and this sign you should keep it in your mind and repeatedly you have to solve some quiz in the ECG. This is very important to remember these signs. Very important to know that the ECG accuracy from the interpretation point of view, there is three conditions should be in your mind. Number one is what you are looking for. What is the circumstance? Is it ischemia or it is arrhythmia or congenital issue? So you have to know what is the most appropriate or linked condition. Also the patient, you have to know what is the patient symptoms, and the interpreter is you, how you approach the ECG. Some people are approaching the ECG by looking for each component. For example, they look for the B, QRS, T, before there is two interval, the BR and the ST, and the QT interval. The QT interval is also very important. For example, the B wave. The B wave, you should look for the B wave in two things. The direction, it is negative or positive. It is absent or present. What is the relationship with the QRS? So if there is dissociation between the B wave and the QRS, this you let you, especially in the bradycardia, you should think about the complete heart block. As you can see in this, this is tracing. In the tachycardia, still the relationship is important because in the tachycardia, if the P is not clear in front of you, you can check in any other possibility within the QRS, can be embedded within the QRS and in the ST segment. You can see it and it can be clearly diagnosed like AV reentry, AV nodal reentry tachycardia is a good example. So back to the bradycardia and heart block, you should know also Mobitz type 2 because this Mobitz type 2 is important because the B wave and BR are within normal, but the B all of a sudden that is not followed by QRS, and again there is B followed by QRS. So, and it is important to know Mobitz type 2 because easily it will convert to type 3 or complete heart block and asystole. The second issue is the QRS. The QRS is important regarding it is positive, negative, wide, narrow, is important. But here I would like to pay your attention about the electrical alternance. This QRS, the amplitude is different from 1 to 1 here. So this is very important in pericardial effusion because sometimes it's overlooked by the emergency physician. The second or third component is the ST segment. The ST segment, of course, we are looking also for ST elevation in the context of chest pain. This ST elevation is clear from myocardial infarction with some, of course, tips and tricks. But again, the ST depression also very important because ST depression, as we discussed in the previous presentation, can be equivalent to ST segment elevation in the treatment and severity. So ST depression is also important because it can indicate ischemia or strain pattern from the left ventricular or right ventricular hypertrophy. So again, you have to look for the ST segment elevation. There is in the context of arrhythmia, because ST elevation, if it is curved, as you can see here in V2 or saddle back shape, these two ECG signs important in young people who came with sudden cardiac death or syncope or cardiac arrest because of Brugada syndrome. Also, there is J wave that you can see it in hypothermia, and also it can cause serious arrhythmia. This is called the Osborne wave. The T is very important also. Big T. The big T, you can see it also early sign of infarction, and importantly in hyperkalemia. This is very important that the P is is disproportionately larger than the R. Sometimes if you see this with wide QRS and prolonged BR with big DT, you can easily diagnose hyperkalemia, especially if the patient is in dialysis and he missed 1 or 2 sessions. Very important in, again, the context of arrhythmia or sudden cardiac death, that to look for this sign again in the ST segment, the QRS and the ST segment. You can see this very epsilon sign of arrhythmogenic RV dysplasia, because it's very arrhythmogenic and cause sudden cardiac death. This one, yes. Again, the important thing is the inverted T. Inverted T, you can see it in very, very serious condition, like acute ischemia, cardiomyopathy, strain pattern, pulmonary embolism, and it is very, very prominent in patient with cerebral intracerebral hemorrhage. You can see this deep inverted, wide, deeply inverted T wave. Okay, sometimes you couldn't find anything special in the ECG, but the patient has a history of dizziness, sometimes family history of sudden cardiac death. You have to look for the QT interval. If this QT interval is more than 10 or 11 small square, you should think about the long QT syndrome, which is also a genetic disease and drug-induced also, and causing significant arrhythmia. Some people can categorize this ECG sign based on some category, like medication. If the patient gives a history of taking medication, like anti-arrhythmic quinidine and procainamide, and he came dizziness or drowsy, then you can think about toxicity of these drugs. You have to look for the AVR. AVR, if you can look for the dominant R in AVR, in such patient, you can diagnose the drug toxicity. Again, in neurology, patient came with sudden collapse, with severe headache and sudden collapse, and disjoint T-wave inversion, cerebral hemorrhage, subarachnoid hemorrhage. A patient came with atypical chest pain, and the QRS alternating, I mean, the amplitude is different. Think about massive pericardial effusion. Hyperkalemia, very important, the peak to T and white QRS and the other sign like sine wave and so on. This also for hyperkalemia, and the patient missed the dialysis. Of course, ST elevation, I think it is easy to pick up, and ST segment elevation equivalent, we discussed it with De Winter in the previous presentation. The important thing in this one is this upsloping ST segment depression. Arrhythmia, young patient came with syncope, sudden cardiac death. Okay, go look for the ST segment and inverted T. ST segment elevation can be curved or saddleback shape. So this is diagnostic for Brugada. Or young and also arrhythmia. So look for the QRS in the ascending limb. You can find the delta wave. So you can diagnose WBW. In ischemia, again, if you can see the left bundle branch block, the left bundle branch block, if it is the QRS in the same direction of the T, what's called concordant sign. Here, the QRS in the same direction of the T, white and prolonged QRS looks like left bundle. You should suspect there is a new infarction. So there is infarction on top of the left bundle, because normally the left bundle without infarction, there is discordant, means the QRS in direction different than the T wave. Ischemia, we discussed the ST depression, but if the ST depression alone in V1, V2, V3 like this, you should, and chest pain, you should think about the posterior myocardial infarction. Cardiomyopathy, if you can see that deep QRS and LV dominant R in dominant R in the lateral lead, or dominant S in the anterior lead, dominant for the left ventricular hypertrophy, it is prominent R in the lateral lead and deep S in the anterior lead. For the RV hypertrophy, it is the opposite. You will see the prominent R in the anterior lead, the deep S in the lateral lead, so you can diagnose hypertrophic cardiomyopathy. We mentioned the epsilon wave, which is very important to know, as it causes arrhythmogenic right ventricular dysplasia. So there is one newly added to the myocardial infarction entity, what's called the South African flag sign, it's diagonal occlusion. You can see ST elevation in the limb lead 1 and lead 3 in the limb lead ST depression. So the 1 is elevation, 3 is depression. This sign coming like this, and the mid to AVL ST elevation, and also in V2 ST elevation. So they make it more or less looks like the South African flag sign. So this is typical for the diagonal for LAD stenosis. We'll take example here that this ECG in young female with recurrent fainting episode. So we are talking about context of arrhythmia because there is fainting attack, or how come? Because also this can happen with exercise in young age. So if I am looking now for arrhythmia, if you look for this, is it WBW? I have to look for the QRS to look for the delta wave. Here there is no delta wave. Welling syndrome is not applicable because chest pain. De Winter not applicable because chest pain. Brugada, sudden cardiac death can be also here, but in Brugada I have to look for the ST segment elevation from cuffed or saddle shape, but no. So again, how come? I have to look for how come the deep S and deep prominent R, no. Then Romano-Ward syndrome, this the QT interval. Then I will look for the QT interval. If it is more than 10 in this female young, it will give the diagnosis of long QT syndrome. This is also very important finding in the ST elevation. It is a bad sign, but this is a stone in the grave. So the ST elevation, it looks like this way. It looks like the stone, the stoning shape. This you can look for the below ECG. This ST elevation. This one is characteristically linked with the 2 or 3 vessel disease, including the LAD. In the same way, there is T segment elevation similar, but taking another special characteristic, which like the shark fin sign. So if you look at this ECG, it looks like the shark fin. Here is the tomb stoning. Here is shark fin. I know shark can lead to the tomb stoning, but these two different pathology. This shark fin is linked to significant left main coronary artery stenosis. And it can be also seen in Takotsubo cardiomyopathy with shock. We discussed this before about the left bundle. This is a normal left bundle ECG, the discordant between the QRS and the T. This is difficult to diagnose MI. But if the ST is going on the STT is going the same direction of the QRS, this is indicate new myocardial infarction in patient with left bundle. But you can see the discordant, but significant ST elevation more than 5 millimeter. This is another sign of myocardial infarction in left bundle. So as you can see in the ECG here, the ST elevation, white QRS in the same direction. This is infarction on top of left bundle branch block. This is the patient who has exertional business.
Thank you
young
for your
with exertional.
Thank you for your patience.
Disability.
We are really exceed our time, but you participate till this time, so thank you for your patience and interest. We are closing the section. See you tomorrow.